We have two amazing speakers today. With me, I have Dr. Bailey-Dorton, who's one of my co-founders, and she's our medical director, and Dr. Mindy Goldman. And so just before we get started, I always like to share why we do this and why we're all here today. So my name is Mariana Arnaud. I'm the CEO and co-founder of the After Cancer. We are a digital platform for cancer survivors, and we help providers like health systems and nonprofits to create and implement and share a survivorship program for their cancer survivors. And so part of what we do and part of our mission is really to share awareness about survivorship because there is not enough information, there is not enough tools and resources out there for clinicians and for patients. And so we started doing these expert insight sessions to be able to share the knowledge that exists out there and give you resources to take better care of your patients. So let's get started with a few intros. Chasse, can you introduce yourself?
Certainly. Glad to be here. I'm Dr. Chasse Bailey-Dorton. My background is trained as a primary care physician, completed an integrative medicine fellowship through Dr. Andrew Weil's program at the University of Arizona. Um, and then I am a breast cancer survivor myself. And as I realized what wasn't available in terms of survivorship through my own experience, started working with a large cancer center to develop their integrative oncology and survivorship program. That was in a large city. I'm currently in a small community hospital, also now developing integrative oncology and survivorship program, and then work with Mariana at the After Cancer to try to take it to a bigger stage. So happy to be here.
Thank you, Dr. Goldman.
Hi, everyone. I'm Mindy Goldman. I am an OBGYN by training. You can see my background. I am at Midi Health. I'm the Chief Clinical Officer at Midi Health. Prior to coming to Midi, my entire career has been on the faculty at UCSF in San Francisco. I have been on the faculty for 30 years, based on a personal experience with a dear friend who got breast cancer and died of it in a year and a half. Um, After helping take care of her, I wanted to shift my career. I ended up working in UCSF's breast care center in the early 2000s. And when oncologists would ask me, what do I do about my patients thrown into menopause, or how do I manage abnormal bleeding on tamoxifen and questions like that, I was shocked that there was nothing there. So fast forward 25 years, I have done research in this space. I feel lucky that I've gotten to do things nationally. I wrote the guidelines for the American College of OBGYN regarding the gynecologic implications of breast cancer. I chaired the menopause and sexual functioning panels for the NCCN, and I semi-retired from UCSF to join Midi because I wanted to help launch a national survivorship program, which we are doing. And I'm really happy to be here.
Thank you so much. Um, I really noticed throughout building the After Cancer and doing these sessions that we all have a personal story that took us here and why we're here today. I didn't know yours, Mindy, but Chasse has one too. And I think that's something that probably a lot of people in this room have in common is we all have someone in our love circle, friends and family, if not ourselves, who've been through cancer. And that's what makes us wake up and do the work that we do and serve our patients, right? So thank you for your introductions. So today we're going to be talking about women's health, and women's health in particularly after treatment. Mina, you just explained what happened, how oncologists oftentimes don't have the resources or the information. And I think we can get started with just defining what is women's health and what are the main concerns that women experience after cancer. Do you want to take the first shot, Mimi?
Sure. Um, I think there are so many women's health issues that are affected by cancer. Certainly, the biggest ones that I probably deal with in my day-to-day career has been managing menopause for people that are thrown into menopause from either chemotherapy, radiation, or being on ovarian suppression or having surgical oophorectomy. That by far is one of the biggest issues. Along with that, and even separate from that, is a lot of sexual health issues from issues of managing vaginal dryness, painful sex, issues related to libido. Also, we know that there are estrogen receptors around the bladder, so a lot of urinary issues like urgency, frequency, urinary tract infections. Those are by far some of the common ones, but there are a whole host of others. Return of menses, safe contraceptives, safety of pregnancy after cancers, depending on what type of cancer. Whole host of other issues from sleep issues to weight issues to fatigue to just getting back to life. And I think all of these interact with each other. But by far, I would say what I focus on most is particularly the perimenopause, menopause issues, and sexual health.
Chase?
Let me kind of build on that. And you're right, Dr. Goldman, we have either our young breast cancer patients who are now put into menopause for their treatment, or we have a woman who's already into menopause, and they go into a state that I call supermenopause. It's everything that a menopausal woman would experience, but to a heightened degree, from brain fog, from joint pain, from body weight issues, from sexual dysfunction and pelvic health issues. And I tell them, I said, look, this is super menopause. We're just now, as you know, we're just now starting to have research onto what menopause is and the total effects of it on our body. And these poor women are going through it to a heightened degree. So one of the questions I ask when I see a patient in survivorship visit, as I go through my list of questions, I do ask about sexuality. And unfortunately, in the cancer experience, I might be the first person to ask them about that. No one else has asked them about that. They're focused on the cancer, which is great, but we're not looking at the whole person. And you're right. It comes from the libido issues, we've put them in menopause. It comes from the vaginal dryness, which leads to pain. So why would somebody want to do something that causes pain? I tell a patient. And so the one question I'll ask you, Dr. Goldman, that when I'm dealing with these young patients is the whole controversy about vaginal estrogen.
Yes.
We know it's a quality of health issue. I know I've got half my oncologists who are prescribe that for a woman. Another half will say, no, that's not indicated. So I would ask you the latest research about vaginal estrogen and our hormone positive breast cancer patients.
Yeah, so I'm so happy you asked that. Um, I will tell you what we developed through the NCCN, which provides guidance. We developed algorithms for different topic areas. And in my years, I was on the inaugural panel since they started in 2014. And we had looked at different forms of vaginal estrogen and safety profiles. There are actually a number of studies that have looked at certain formulations. In breast patients, it is most concerning for people that are on aromatase inhibitors. Those drugs, as you know, function by shutting down all estrogen production in the body and make people into that sort of super menopause state. And so it's biggest concern for those patients whether it is safe to reintroduce vaginal estrogen. We know that in the general population, vaginal estrogen is recommended to target vaginal symptoms. The estrogen stays locally with minimal systemic absorption. There have been studies that have been done specifically in breast patients on aromatase inhibitors, looking at the suppository formulation and the ring. We actually at UCSF did the largest study to date looking at the ring formulation, and those formulations specifically have not shown rises in blood levels of estradiol, suggesting safety. Just last year, there was a beautiful meta-analysis and systematic review that was published in March of 25 that showed no impact on survival with any form of vaginal estrogen in breast cancer survivors. And I use that a lot in my counseling to patients to say it is the most effective treatment for genitourinary syndrome of menopause. We don't have any studies showing it impacts survival from breast cancer. In that trial, the only concern was when they did their analysis, there was a 2022 Danish trial that had shown a higher risk of recurrence for women on aromatase inhibitors who use vaginal estrogen. That trial was observational, and in the same trial, they did not show any higher risk with systemic hormones. They also have formulations, it was not in the US, they have formulations of hormones not used here. And there are a lot of issues that were raised about that. And my take is that vaginal estrogen can safely be used. I think if we have someone who is on an aromatase inhibitor, I am more apt to give them an yeast ring or suppositories, Vagifem, Uvifem, Imvexi, the lower formulation, but suppository formulations. Creams can safely be rubbed into the opening, suburethral area for people that have urgency, frequency. But generally, for my patients who are on an I will tell them to avoid the creams in the usual way of putting a gram inside the vagina multiple times a week, but using it with finger application, totally okay. And I think we should stop denying breast patients vaginal estrogen. And I do also say, with removal of the black box warning, I think that we are seeing certainly more broad use of hormones. There's shortages all over the country, partly related or mostly related to that. But I think in the wording of some of that, they also talked about the fact that the concerns with vaginal estrogen were way overstated and equated with systemic hormones, and vaginal hormones are not the same as systemic hormones.
Yeah, thank you. And that's the same story that I give my patients, whether or not some of their oncologists are on board with it or not. I've actually found that with the patients on tamoxifen, they actually have a vaginal discharge, which can kind of help with some of the dryness problems.
Exactly. Although sometimes I found it's a little bit irritating.
Yeah,
So
yeah.
helps, but irritating. One thing that I have created at Midi, for people who don't know, we are a medical practice, telehealth practice, 100% telehealth, insurance covered in all 50 states. And one of the things that I have created, because I know this is a concern, is we send letters to patients' breast team, whether that's their surgeon, oncologist, survivorship nurse practitioners. And in those letters, we talk through this is what we recommended, these are what national guiding organizations say. And then we give references that I continually are updated to support our treatment decisions. And I think that's been helpful to many oncologists are focused appropriately on the oncology care, but some of the quality of life things, they may not know the literature as well. And so I feel in sharing that information, that's an important part of survivorship care.
I agree. Also, a high utilizer of pelvic physical therapy, certainly with some of my breast patients, but also a lot of the GI cancer patients who are getting pelvic radiation or a GYN cancer. You know, there'd be a great role for having it prehab. That doesn't happen enough, but using those pelvic health physical therapists can really help in some of these situations too.
Totally. We do see for our anal cancer patients,
Hmm.
people that are going to get radiated, we try to see them for vaginal dilator therapy before their treatment so that they understand what that's about. Across the board, almost everyone that I am seeing that has some form of sexual dysfunction, I almost always am sending to pelvic floor PT. We know that if you have, as you so nicely mentioned, you have chronic pain, it hurts to be touched. Who's going to want to do something that causes them pain? But that oftentimes sets up some degree of pelvic floor dysfunction that I think it is something that almost everyone can benefit from.
I agree. I think the other thing that I'm seeing a lot in young patients who are put into menopause are the hot flashes. Coming from an integrative background, I like to refer to acupuncture I'm currently in a community setting where it's not available, but I think that is one of the first line therapies I like. But also, there's some of the newer medicines that are out there for us, some of the Vinzoza. I don't know if you wanted to speak to that in terms of treating hot flashes.
Sure. One of the things that I try to tell my cancer survivors is do not let anyone tell you that you just need to deal with the side effects. We have we have treatments for virtually all of the symptoms people will have, whether that is drug therapies, integrative therapies, supplements, herbs and botanicals where evidence exists. No one should feel that they have to suffer. I think it's different than when you can give hormone therapy, and that's a whole other controversial area that I'm happy to touch upon. But I think of it when you can give systemic hormones, it sort of is a broad treatment that affects many symptoms. But when you can't give that, you target the individual symptoms. And for the hot flashes, the vasomotor symptoms, I think we have some of the best treatments. So we have a number of off-label prescription medicines and we have FDA-approved medicines. The off-label ones are low doses of a number of the antidepressants, neuropathic pain medicines. There was an older blood pressure medicine, not used as much, and overactive bladder medicine. All very diverse drugs, all interestingly used in lower doses, or many of them in lower doses than what the drug is intended for. And in the past, we would say, we don't know why they work, but they cross the blood-brain barrier and affect the temperature regulation zone within the brain. But we weren't exactly sure why they worked. We now have 3 FDA-approved drugs that are non-hormonal for treating hot flashes, and 2 of them explain to us exactly how hot flashes occur. The first I'll talk about that is not those 2. The first is a drug called Brisdil, which was a brilliant marketing ploy. Most people have heard of the antidepressant paroxetine or Paxil. The lowest dose of Paxil that's used for depression is 10 milligrams. They studied a 7.5 milligram dose for hot flashes, found it effective, got it through the FDA, and changed the name of the drug since it was a lower dose to Brisdil, and people don't think they're on an antidepressant. It is an antidepressant, just a lower dose. I have found that many insurers do not cover that, and so oftentimes you have to give them standard Paxil, and people are cutting it in half. The 2 new drugs, first drug hit the market. It's called Veozah fezolinetant. It hit the market in 2023. This targets the specific area within the hypothalamus of the brain where hot flashes develop. It's targeting what's called these candy neurons. It is the first drug that we understand the mechanism of how it works. It is very effective. When they got it through the FDA, interestingly, they excluded cancer patients from the trials, although it is most of interest, particularly in breast cancer patients or people who shouldn't be using hormone therapy. A year ago, there was a case of hepatotoxicity, and the FDA put a black box warning on Veozah, which I think is limiting its use somewhat. It is still a very effective drug. The black box warning, unfortunately, requires baseline liver functions months 1, 2, 3, 6, and 9, which is a hassle, but it should not take away that it is a very effective drug. Now, Veozah targets what's called the NK3 receptors. A similar drug called islinetant. The trade name is Linquit. I hope I'm pronouncing islinetant right, but the trade name is Linquit. Got FDA approval, I think, in November last year. It targets both the NK3 and NK1 receptors. Because it has a little broader coverage to these receptors, in the trials that led to its FDA approval, it also improved sleep. It is not FDA approved as a sleep drug, but I really like this because it does help out with sleep. Many people who are having hot flashes have them at night, have sleep difficulties. It also does not have the black box warning on it. It requires baseline liver functions and then again at month 3. So I think it offers a great option for people. The problem is, as with any newer drug, it is not on many insurance plans. There is a pharmacy called Blink RX that will try to, they're somewhere, I actually do not know where they are located. Could be Indiana, but I'm not sure. But they will try to run it through someone's insurance. And if they can't get it through insurance, right now they are at least offering that for $25 a month for patients. So what I try to tell people is if you have hot flashes, you have many, many treatment options. And I think if you treat the hot flashes, oftentimes you're going to improve sleep, which is going to improve fatigue. We have lots of studies that say people that are chronically fatigued aren't making healthy food choices, aren't exercising as much. So the whole cascade of improvement that you can have on many, many symptoms by treating those hot flashes, I think is huge.
Those that I have had trouble getting some insurances to cover it, but those who have
Yeah.
used it have had good luck with it. And you're right, I've had patients come in with complaints of fatigue and insomnia, and I'll see other providers will then put them on a sleeping med or do something else. I'm like, well, you got to go back through and see the actual cause. Why aren't they sleeping? They're not sleeping because they have hot flashes. And so let's treat the hot flashes first to see how the sleep improves, see how the fatigue improves and all that. So it's tied together. We're just not looking at it correctly sometimes, I think.
Exactly. I
And,
love it. It sounds like we approach our patients so in so much of the same way.
exactly. Now, the other issue I see with a lot of the patients is bone health issues.
Yes.
I'm huge on my patients get into an exercise program if they're not doing one already. I've been using a quote that I can't give the correct source for that I've been using with patients is that we don't lose muscle because we age because we lose muscle. Trying to
Mhm.
get our patients to exercise. But I don't know if you want to comment about bone health. We know the aromatase inhibitors affect bone health, but if you
Sure.
wanted to speak on bone health issues.
Yeah, I'd also love to speak just on exercise in general. Um, we have data that specific amounts of exercise, 150 minutes a week, divided times, interval cardio, can decrease risk of recurrence, primarily for hormone positive breast cancer, and improve overall survival. I will tell my patients it is as important as popping your tamoxifen or your aromatase inhibitor to do that amount of exercise. In the general population, we have increasing data that that amount of exercise decreases the likelihood of getting breast cancer, colon cancer, liver cancers, and some others. I think we are trying to understand the mechanism as to why is that. And my understanding is that it may have to do with effects on inflammatory markers, local inflammatory markers within muscles, within bones, sort of cellular inflammation. But if there is one thing that I try to encourage my patients to do, it is moving as much as they can, and if they can get that amount of exercise. Exercise certainly hugely important for bone health. Women reach peak bone density in their 20s to early 30s. Everyone loses after that. We see the major rate of bone loss in the years immediate after menopause, 2 to 3% per year. And you see more bone loss for women on aromatase inhibitors. So, um, for many people who are on aromatase inhibitors, as you know, they end up needing to be on other drugs like bisphosphonates to maintain bone density. We do see higher risk of fractures when women are on AIs. Although there is evidence that says once people stop their AIs, it's not that those higher risks of fractures persist. I think it is so important for all of us in the survivorship space to be talking to our patients about bone health. We need to make sure we are getting bone densities. I think sometimes people don't think about it. You have a cancer patient who's thrown into menopause at 38, on the top of someone's mind may not be, I need to think about bone density, particularly if they are not a breast cancer survivor and they have another type of leukemia, lymphoma, and someone doesn't necessarily realize you need earlier bone densities for people who are thrown into menopause early. And there are many drug available for people who do have early osteoporosis. I talk to my patients of ensuring they are taking sufficient calcium and vitamin D. We know that too much calcium isn't good from a cardiovascular standpoint, but ensuring that people are getting at least 1,000 milligrams of calcium, whether that's in dietary with supplements, and a minimum of 400 international units of vitamin D. Many of patients are vitamin D deficient and may need supplemental vitamin D on top of that. I also will talk to my patients sometimes about devices. There's weighted vests and things that, even though I know some of the data has shown improvements in bone densities, we haven't seen necessarily fracture data, but anything that people can use that they can get out there to make sure they're moving, helping to maintain their bone density, preventing osteopenia and osteoporosis, hugely important.
Yeah, and I agree with you. And also, a lot of women, when they finish their active breast cancer treatment and they're getting ready to go on endocrine therapy, they have a lot of concerns because there's a lot of information out there about side effects. And I usually explain to them from my experience, women who are about to start either a tamoxifen or aromatase inhibitor fall into one of three buckets. One bucket they get on, they actually do pretty well. Second bucket they get on, they might have the side effects from the hot flashes or the joint pains or that we can deal with integratively. And there's that small percentage that get on it and just can't tolerate it, and then they can be switched to something else. But we don't know which bucket a woman's going to fall into until they get on the medication. So I try to encourage you to at least give this that trial to figure out where you're going to fall. Um, the other issue that I see a lot in women's health in cancer survivors is weight. A lot of people think, oh, we're going into treatment, we're going to lose weight. Actually, a lot of our young breast cancer patients gain weight during chemotherapy. A lot of our other patients, through some of the GI cancers, end up gaining weight. But when these patients are thrown into this menopause, I tell them, look, move more, eat less does not work for the weight gain in this menopause. So I don't know if you want to touch on how we help our patients maintain that normal body weight or get back to that normal body weight.
Yeah, that's a huge issue. I think some of it is also effects of being thrown into menopause. We are learning more and more about the metabolic effects of estrogen. We know that metabolism slows in the perimenopause and menopause. We do see weight gain in the general menopause alone. You see an average of 5 to 7 pounds of weight gain in the immediate years after menopause. We are learning more directly about estrogen effects on fat cells and metabolism and insulin resistance. We see higher risks of diabetes goes up after menopause. So some of this is a result of directly being thrown into menopause, again, whether that's from surgical menopause, from cancer treatments, from chemotherapy-induced menopause, from radiation-induced menopause. Um, Certainly, all of the lifestyle things are important. We already talked about exercise, that it can improve outcomes, but I talk to people about the importance of exercise and trying to maintain their a healthy body weight. We talk to people about diets. I think there is the NCCN puts out a lot of, and ASCO, a lot of good information about types of diets people should be on, more of the Mediterranean type diets, more of their fat from plant-based sources than animal-based sources. I think there's less direct data that improves specific outcomes, but we are not telling people things that are unhealthy for them. But I also tell people, don't try to make yourself crazy. We do minimize things like alcohol. There's data that alcohol is a risk factor, particularly for hormone positive breast cancer. And so people should try to minimize that. Alcohol also has an impact on weight. All of that being said, at Midi, we have a very structured weight program that involves a combination of lifestyle, diet instruction, nutrition, and also med management when it is appropriate. And so there is a lot of interesting data coming out looking at drugs like the GLP-1s on breast cancer. Just yesterday, someone sent me an article suggesting improvement in overall survival for breast patients who are on GLP. I am not advocating that all breast patients or all cancer patients should be on GLPs, but I think there is a lot of interesting literature looking at that. Again, those meds are thought to act by decreasing cellular inflammation. There is a lot of interest and thought that many diseases develop because of inflammation, whether you're talking of autoimmune diseases like diabetes, thyroid disease, cancers, cognitive loss, and there is broad interest in drugs like that for a whole host of people. So we have a whole protocol. We will check complete metabolic profiles on people. Many people develop prediabetes. If you look in menopause, as many as 40% of menopausal women will develop prediabetes. That can be treated. Prediabetes also means you are have some level of insulin resistance, and that is going to also impact weight. So I think we should be more broadly treating prediabetes. I see a lot of my patients come in and say, well, my internist said it's only prediabetes. They're just going to follow it and recommend that I do exercise and diet changes. I'm not so sure. Particularly in my cancer patients, I am a bit more aggressive in treating prediabetes, and whether that is drugs like metformin or consideration of drugs like GLPs. I just think we should be looking at the patient as a whole, and weight very much should be taken into consideration. We also know there's data looking at outcomes, and people do better when they are closer to their normal body weight. So I think it's an area we need to talk to people about their concerns. I don't think when it's indicated we should be afraid to use medications. I think that interesting area and a lot of people ask about is, well, what about if you really don't meet criteria for these drugs, but you gained 7 pounds and it's bothersome? Can that be considered? And can you do microdosing of drugs like GLPs? And I think that's an evolving area that we are still getting information on. But there are a lot of interesting things looking at those drugs. I met with a breast oncologist this week who wants to look at the impact of GLPs on breast density, as well as on bone health. So I know that's sort of, I'm not trying to promote GLPs for everyone, but I do think that we should be talking to people about weight. I don't think we should be saying, oh, sorry, you don't meet criteria for any meds. We need to understand what's bothering people. We need to help people be moving more. We need to help them eating well and talking to them about what they're eating. But we also need to be assessing people for medication use when it's indicated.
I agree. I think there's a lot of studies coming now on GLP meds and cancer survivors because we do know obesity is a risk factor for multiple types of cancer.
Totally.
So the research is coming. I think we'll get the answer soon. The other thing that I often do, there is a study showing overnight fasting of 13 or more hours overnight in decreasing breast cancer recurrence. And I have had patients tell me they sleep better, they have less hot flashes. Some of them have been able to maintain weight during that because some of the other fasting studies was done on young college guys, and it's not applicable to a menopausal woman or some of our survivors, but I do recommend that.
Yeah,
So,
it's interesting. I saw some interesting studies about that for people who are in the middle of chemo and looking
mhm.
at whether it impacts how effective chemo may be when you put people into a fasting state.
Yeah, there's a few
Again, I
studies
don't know
looking
the
at
literature as well, but I
Yeah,
have.
there's a few studies looking at chemotherapy and breast cancer and that low calorie fasting mimicking state that they do
Yeah,
better. It goes back to the premises is that a healthy cell can kind of hunker down and handle this fasted state where a cancer cell is abnormal, is not going to be able to handle it, may be more susceptible to the chemo, but that's some interesting research too. The other area I see a lot when we're dealing with cancer survivors is the end of treatment. So, as stressful as it is for that patient diagnosis, where they feel like they've been thrown into this hurricane, the end of treatment is often even more stressful. You know, they're going from this environment of seeing their oncologist, their nurse navigator, their clinic nurse, their infusion nurse regularly to be and say, we'll see you back in 3 months. And that's a scary time for patients.
yeah,
And they're going through the thoughts, well, I didn't know I had this in the first place. Now I have these side effects. Is it going to come back? Will I know if it comes back? And can I do anything to keep it from coming back? And I think this is a great opportunity to get in there and deal with our survivors to help them recover and really make them healthier for having been through this. Some lifestyle medicines and some other changes that we can do.
Exactly. I think it speaks to the whole reason that we need more programs like the after cancer and survivorship programs out there nationally, because I truly believe that cancer survivors should be followed, specially by people who understand cancer survivorship, know the questions to ask about recurrence, know how to counsel people, understand the issues that they have of concern of getting back to life. How do I not worry about cancer all the time? When do I need to worry if I have a certain symptom? And so I think we need to more broadly be teaching survivorship. For any survivorship should be a part of every cancer program across this country. I know in the NCCN, in my years working with them, they were very proactive and said, we're going to create guidelines for survivorship, even before there are mandates saying it has to be a part of cancer treatments. The problem that they have run into is that the resources available at different places across this country that provide cancer care all vary. And how you do survivorship because of that oftentimes varies. And so I think it's important to provide a framework of all of these topic areas that are needed and crucially important for survivors, and get that information out there broadly. So, I appreciate that you're even allowing me to come and talk to you today about some of these issues, because I see this, it's hugely impactful to people's quality of life.
And that's part of how the after cancer is developed, is seeing this gap in survivorship care. Because, there's always, we know our oncologists, the workforce, it looks like the workforce is getting smaller. They seem to be overworked. Same thing for our primary care docs. So it's like, well, who's doing what? Are you doing the survivorship care? Or are they doing the survivorship care? And you're correct. The programs either are non-existent or are piecemeal at a lot of these places. But the other thing that a lot of our survivors we could talk about is just this fear of recurrence. And this, I tell my survivors, this cancer is going to be like an elephant. This elephant's going to be with you for the rest of your life. I'm 24 years out. My elephant's small and in the corner. And people's elephant varies with either it's a mammogram, or if they're a GI colonoscopy or having blood tests. So this fear of recurrence is a huge issue that our folks deal with, and trying to provide resources for that. I don't know what you guys provide at Midi Health in terms of that.
Yeah, I think one of the important things is educating clinicians to talk to their patients about that. What are you fearing? What are you worried about? What is bothering you? Do you have a symptom? Like understanding, first of all, what are the questions that you should ask someone, for example, with breast cancer? We know if breast cancer recurs, it recurs locally, bones, liver, brain, right? We need to ask about specific questions related to those areas for recurrence. Are you having any bone pain? Are you having any unusual stomach pain? Are you having any unusual headaches that aren't going away? For most people, luckily, that's not going to happen. Cancer isn't going to come back, but clinicians need to know, depending on the cancer, the questions they need to ask to screen people to determine, do they need to recommend any sort of testing to be done. Then clinicians also need to know, these are the issues that are of concern to people, of how do I get through life constantly not being worried about a cancer recurrence, asking them what they're worried about and providing the resources that they need to help them deal with some of those issues, whether that is, I think we need a heck of a lot more when people are in treatment, things like psycho-oncology. I see a big gap in places that offer that, or when they do offer it, it's months to get in, and there's not enough services that are out there. So whether it is offering therapy, support groups, I oftentimes speak in this group for cancer survivors diagnosed under the age of 50. Their needs are different than people who are diagnosed in their 50s and 60s, And it is really helpful having a group together, a community where they can talk to each other. So I think a lot of it is behooves us on the medical side to be getting this information out there and ensuring that there are more people doing survivorship. One of the things I've created at Midi is a whole survivorship program that our nurse practitioners have to take and pass so that they understand these issues and feel comfortable talking to survivors. You mentioned before that things like sexual health, oncologists don't bring it up. There's lots of studies that show they feel uncomfortable, so they don't bring that up. We should feel comfortable talking about all of the issues that are important to survivors, and we should know resources to provide for them. If we don't have them, we need to know what those resources are to be able to send someone to an expert who can talk to them about these things.
It's true. In addition to our young breast cancer survivors, we have now this peak in GI cancers in folks under 40. So a lot of clinics are having to be developed for that. And, a 40-year-old or somebody less than 40 has different issues. They're still maybe have children in the home. They're probably working full time. They have that other caregiver role. And it's a whole complex issue that we're not always set up to deal with some of these things that our women are typically having to deal with.
Yep, exactly. I see a lot of people coming in wanting to talk about uh, pregnancies after cancer.
Hmm.
And, can I get pregnant? When can I get pregnant? Do I need to worry about a recurrence when I'm pregnant? All of those issues. And that is, I think, if you look there are many people that aren't trained to answer these questions. And so if you aren't, you need to be able to make sure you can get your patient to someone who can help answer those questions.
And I've really seen that whole area of fertility preservation, how much that is expanded, and, testing, ovarian reserve and some of the things for our young breast patients or any young cancer patient. And it's not available.
Yeah, we try to get the two things in that space. One is when it is possible, we try to get patients in before chemotherapy to reproductive endocrine physicians to talk about whether assisted reproductive technologies, freezing of eggs or freezing of embryos, is a possibility, both a possibility from the standpoint of the cancer as well as standpoint of cost. It is cost prohibitive for many people. Insurance doesn't always cover that, but you want to at least have someone have the ability to talk about it before that window is closed. So before someone gets chemo. The other thing is there's interesting studies that have looked at giving ovarian suppression to young patients uh, with their chemotherapy to put the ovarian follicles in a resting state. And they have looked at in breast patients a few things. They have looked at return to menses, fertility, and whether it improves outcomes from breast cancer, decreasing risk of recurrence. What they have found is for the people who get ovarian suppression with their chemotherapy, they have sooner return to menses. There's a suggestion of improved fertility, no difference that we've seen in overall outcomes. But for people that can't afford to do assisted reproductive technologies, or it's not feasible because they need to start chemo right away, that is a potential option to preserve ovarian function. And I would say, not just from the fertility standpoint, but we know that the estrogen that the ovaries protects from many diseases. We've talked about bone health. It protects from cardiovascular disease. The risk of cardiovascular disease goes up in women after menopause at about age 65. It's equal in men and women. And we know that estrogen is protective for the heart, is protective for the bones, and there's increasing data that it is protective from a cognitive standpoint. And so if someone has return of ovarian function, it can provide them with other non-cancer benefits that can be important to their overall health.
Great. Mariana, I'm going to turn it back over to you if we want to do some questions from the participants. I think Mindy and I have done enough back and forth
You
here. We'll
think,
turn it over to them.
oh yeah, you took over today, but I'm happy. I love it. And I'm having fun because I know both of you personally, but you don't know each other, and so I just love that you see like the the chemistry and
We have
again.
clearly approached people in the same way. I'm so happy to meet you.
So we have a couple of questions here on the chat. The first one came from Mary, and she's asking, for a woman with ER and PR positive breast cancer, is it ever okay to use estrogen products?
Okay. So we already talked about vaginal estrogen. And again, no trial has shown that the use of vaginal estrogen in women with breast cancer impacts survival. Vaginal estrogen is safe for virtually all patients, including patients with hormone positive breast cancer. We typically will recommend specific formulations for people that are on aromatase inhibitors in particular. Systemic hormones. So I will give you my overview of hormones in general. We have been biased a lot by the Large Women's Health Initiative. The Large Women's Health Initiative was designed to see whether the use of hormones prevented heart disease, the most common cause of death, and there was a lot of bad publicity when one arm of the Women's Health Initiative was stopped in 2002 with the finding that the use of a specific form of oral estrogen and a specific synthetic progestin increased the risk of breast cancer. That is when the black box got put on hormones that was on up until a few months ago. We now know the results of that were overblown. It impacted the gap in menopause care. It impacted the fact that most women in this country fear hormones specifically related to breast cancer. What never got stated in the Women's Health Initiative was the group that got estrogen alone. In that trial, for women who had a hysterectomy, so didn't need progestogens, so progestogens are used to protect the uterine lining. For those women who got estrogen alone, there was a lower risk of getting breast cancer. And if you look at studies since the Women's Health Initiative, in the general population, the risk of breast cancer is largely confined to studies that look at combination estrogen and a progestogen, and specifically synthetic progestins. Nowadays, when we use hormones, we use bioidentical formulations, which means forms that are similar to what our ovaries produce, bioidentical estrogen and bioidentical progesterone. And if you look in the general population, the risks of breast cancer are largely confined to studies with synthetic progestin, and bioidentical progesterone is thought to be more breast neutral. Now, when you look at, I gave you that as background. When you look at studies looking at breast cancer survivors, particularly those with hormone positive disease, there have been three big, large randomized control trials. One is called Habits, one is called Stockholm, one is called Liberate. Let me move Liberate off the table. Liberate looked at a drug called Tibolone, and they found a higher risk of recurrence in breast cancer survivors using Tibolone. Tibolone is not available in the US. So the two trials that pertain to the US are Habits and Stockholm. They showed conflicting results. One showed no increased risk of recurrence in breast cancer survivors using hormones. The other showed an increased risk of recurrence. The problem is those studies use the older formulation of hormones that I talked about in the Women's Health Initiative. They used them a little bit differently, but they use synthetic progestins. The gap in the literature are studies looking at current formulations of hormones that we know are more breast neutral in people with hormone positive breast cancer. So what we have done at Midi is we will counsel people when they have completed their adjuvant therapy and they are coming in asking us about it. We will say, this is what we know in the general population. This is what we know in breast cancer survivors. And these are the gaps in the literature. Depending on how severe someone's symptoms are, what they are willing to accept for potential risk of recurrence, with shared decision making, we will offer hormone therapy. Where I want to see the field go and what I am hoping to do, we have a whole Midi Research Institute, is I would like to see if there are tests that we can think about doing to stratify patients to figure out who are good candidates for hormone therapy. So an interesting test that I am hoping to study is a test called Signatera. So Signatera has been used to, it's not yet part of standard clinical care, but it looks at what's called CT, circulating tumor DNA. And there are studies that show that people that have a positive Signatera have shorter time to recurrence. And people that have a negative Signatera are less likely to recur. I don't know any data out there about using Signatera for looking at could we stratify someone, and if they had a negative Signatera, maybe they're a good candidate. I can tell you I've done it for a few patients who come in who are higher risk, and I said I feel very uncomfortable, and we use that. No, again, there is no data on that, but I am trying to think outside the box of in the future, that's where I hope we're going, of thinking about no cancer is the same. We know that breast cancer is now a compilation of many different diseases. And for the people that have hormone positive disease, I'm hoping like another potential option. If you look at, there is now a new type of very low risk mammoprint that is being done to look at people who may need less than the typical 5 years of adjuvant endocrine therapy. Those tests are designed to look at use of endocrine therapy. They are not designed to look at stratifying people for the use of hormones, but maybe that's a study that could be done. So we have more than 4 million survivors in this country. We need to start seeing studies done to help us figure out which patients can safely do hormones, because I think the day should be gone that we say blanket across the country, you had hormone positive breast cancer, hormones are off the table for you for the rest of the rest of your life. I think that we should not be saying that anymore. So long answer, I know, but I hope that that helped answer that in detail. And I know I wanted to go into that detail because so many
Yeah.
people have questions about the use of hormones after breast cancer.
That could be just a whole session by itself, couldn't
Exactly,
it? Maybe
exactly.
we'll have to do a take two because I had it on my questions. We have 5 minutes left, and there's a really good question here on the chat that I would love to cover, which talks about body image issues, which is something we didn't talk about. We talked about weight gain, we talked about changes in our body, but not body image issues. And so Lauren is asking, what are your thoughts on the health at every size approach? How does this, along with body image concerns that can arise from weight-focused treatments, get incorporated into your survivorship programs?
Yeah, hugely important. And thank you for bringing that up. I think as providers, we don't bring that up enough. Separate from weight, lots of body issues when you have things like breast surgery, whether it is lumpectomy, mastectomies, bilateral mastectomies, reconstructions that work, don't work. You have deformities of the breast and other cancers as well, colon cancer, and you have a bag. You know, there are huge body issues that we need to be talking to people. Again, in my experience, I think this is where community helps and talking to other people that have similar issues, have had similar surgeries. Maybe they've had similar complications. How have they dealt with that? I think we need to be educating people about things like preparing to be sexually active again after you've had something like a bilateral mastectomy, and what issues come up. Asking people, what are your issues of concern? We can't go back and change if someone has had surgery. Certainly, we can go back and do reconstructions and things for people that have complications, but there are a lot of people that are going to have body issues post-treatment, and we need to be aware of it and ask people what are the conditions, what are the concerns that they have. Pain. I think a lot of people that have surgeries and reconstructions, people may have also pain that we don't think about how that's going to affect their sexual well-being and their overall health. So again, it behooves all of us in survivorship to be asking people about what their concerns are, trying to find solutions, and trying to find a community for them.
We've had a lot of luck with that at the after cancer. Some of what are called our circles, where other survivors are communicating with each other, and the concerns they bring out of there have helped us develop some more of our programs too.
Perfect. Thank you so much. Always learning from you too. Thank you so much, Mindy and Chase, for sharing your knowledge with us today. So this session was recorded. We're going to share the link to the YouTube video by email. We're also going to post it on our social media. So follow us on LinkedIn and you'll get it. And it's always a pleasure. And feel free to share if you have any other questions that we couldn't answer. You can share them and we'll try to get the answers and share them with everyone. Thank you.
Thank you so much for letting me be here today. I really enjoyed talking to you all.